Welcome to this week's Office Hours. I am Kate Tingley, Director of Marketing here at Infinix, and am thrilled to be joined by our VP of Strategic Accounts, Bowman, this week. Bo has many years of experience in revenue cycle, medical billing, so brings a lot of knowledge to the table, and we're going to focus on contract negotiations. So welcome, Bo.
Hello, afternoon.
All right, so let's jump right in. Contract negotiations are tough for a lot of practices. Tough and something that I think can seem intimidating, overwhelming, and tough to kind of know where to start. So why don't you kick us off and let's talk about what the biggest challenges are that you see clients having in terms of contract negotiations.
You know, I've worked in kind of two arenas in physician practice administration and kind of hospital reimbursement and payer reimbursement. And, you know, there's kind of three. I was thinking about just kind of what would be best for the audience today, hopefully. And there's kind of three things we focus on. It's size, geography, and scope. So, you know, size wise, if you are, you know, a large specialty group and you're, you know, renegotiating a contract, you don't necessarily, you would just immediately think that you have advantages that maybe a smaller 2 or 3 person medical group may have. And years ago, that was probably the case, but you know, one of the biggest challenges there are now is if for some reason you were to change your tax ID or to, you know, start a new location and a new practice, it doesn't necessarily mean you're going to get the rates on the contracts that you started for your group either a year ago, 2 years ago, or whatever. So, you know, there's some logistics to think about as a group tries to expand. And that's oftentimes when we move into the contracting space, right? When a group is either going to expand or maybe start a new branch of themselves or maybe consolidate in some fashion. So challenge there is number one, size. You know, try and figure out how to have the most advantageous number of providers in your group. And you know, a good way to do that is to consistently run on a regular basis, you know, what your volumes are in the shape of CPT codes, and ultimately what you're going to be billing by payer, and just stay cognizant of your size and what's most advantage, you know, for the specialty you're in. The next one I put was geography. You know, Blue Cross Blue Shield is real big on providing specific rates within specific areas. Enhanced Revenue Solutions by Infinix is in Texas, so we talk quite a bit about Blue Cross Blue Shield germane to your area or then rest of Texas. And sometimes the rates can vary by where you are. So again, if a group is in expansion, consolidation, or just looking to improve their reimbursement for each clinical episode they provide, it does make sense to be very aware of where you're going to be located. And you know, that's a tough one too, because being in the centric area of a big medical center, does that likely bring you better rates from a contracting perspective? Typically it does, because it's an area where there are a lot of services that are representative. But in today's market with expanding, I guess, strategies on how to set up either your primary care or specialty practice, or maybe even your ambulatory surgery center, you see new medical facilities pushing further and further out from the large medical center traditional home, you know, into the more suburbia areas and even new parts of town. So sometimes from a contracting perspective, that may not be as advantageous if you're truly not connected, you know, to a larger entity. So again, something to think about on geography. And then lastly, I just put scope. You know, a group with a large range of services, maybe a large gastroenterology group or similar that does, you know, the full breadth of services and has multiple surgery centers or similar labs, you know, they're going to have a better time at the contracting table and getting the highest rates because they're bringing in payers from patients and payers from maybe all over a region, and they're negotiating as one single large group versus, maybe a two-man GI practice on the edge of town. So just, again, real important to think about, do we just have, say, 20 or 30 codes that we bill for in our office? And if so, where is that going to lead us in, what kind of rates we could potentially get versus, if we were in a consolidation model, or if we were a branch. You see this quite often in the dental industry. If we were a branch of a larger entity, will that provide us economies of scale and scope to have higher rates? So again, just something to think about there. But those are, those are all complex challenges. Nothing I just said there, has a yes or no answer, but must be tactically and thoughtfully, thought through as the group tries to expand or maintain its revenue.
What are you seeing in terms of impact on core negotiating for practices?
I was thinking about that one too earlier and kind of discussing it with some colleagues online. And we came up with a few things that really all lead to lower reimbursement at the end of the day.
Right.
Poor negotiating ultimately leads to lower reimbursement. That's not a surprise. But first off, again, kind of back to scope. So fewer covered services, right? If you're negotiating either with a payer or maybe you've moved into a value-based entity or situation, there's one thing you want to do is, if your practice covers, I'm thinking of either maybe a large PCP group that has women's services, dermatology, all types of other things. If your practice does all of those things, well, then that needs to be represented in the contract, right? And then maybe on the other hand, if you're a large procedural group, orthopedics, cardiology, GI, or otherwise, you also need to, as you're moving through, show the full breadth of your CPT code to show everything you do. So as you select the payer you're going to negotiate with, you don't potentially want a contract with a payer that's only going to cover half of the codes that you potentially can bill out for, right? That's not worth your time. And so that could happen, right? That could happen in some of the smaller payer plans. I call them regional plans that we see either locally or to a particular market. And so you've got to weigh that value proposition if it makes sense for your practice. But again, fewer covered services. I put lower volume of a particular payer. Again, if it's a small plan and then they're covering maybe an employed plan for a one that I've had to deal with in the past is Tyson Chicken or State Farm or a Mutual of Omaha. Those are all great employers, and oftentimes they negotiate a very narrow network, and so that lowers your rate, and arguably you get into trouble there when you start seeing those patients because what you're bringing in doesn't cover your costs. So those are some of the pitfalls of a bad negotiation.
What about how often providers should negotiate their contracts? I feel like in my experience, I've heard a lot of folks just say, it's not worth it. I'm just going to leave it as is. It's not worth taking the time and energy. I'm not going to get any more reimbursement. But what's your opinion on that?
Well, I mean, there's some truth in that. I think it's very important. I've seen groups go ahead and split up and 3 go this way and 3 go that way and 3 move across state, and then they all catch up with each other a year later and they say, how's it going? And they explain, well, if we still would have been together, our contracts would have been a lot better and we'd be making more money per episode. So I think it's important to focus again on, if you're going to have an event in the group, an expansion event, a consolidation event, it's time to take a pause and look where you are on your contracts and look what your reimbursement ultimately is. If it's above the Medicare rate, that's wonderful. How high it is, and what codes does it cover, and do you have good relationships with the representatives of the 5 or 6 major payers? I think those are all important things. And then as for either a review or a renegotiation, again, kind of hard to put a recipe or a
Right.
formula on that because each payer is so different. You may have rates from your 2015 contract that would be much better than your 2023 contract. So again, I'd highly recommend using a contract specialist or a consultant to review those with you. These people are out there, they exist. If not, you can contact our group and we can connect you with one. But important oftentimes to just understand where you are before you jump onto something else.
Good advice. You mentioned value-based care minutes ago. What are you seeing in terms of those value-based care contracts and what the impact is around them?
It's funny, we used to say, well, value-based care is the future. Well,
right.
The future's here, and it's been here a while. I've spent the bulk of my career in Central and South Texas, where United Healthcare has a large value-based medical group under the WellMed flag, and that model works great in many instances. As you continue to try and grow and expand your services as a medical practice, you don't have a real choice anymore. You need to align with the value-based care quality metrics and ensure your practice has really the competency to perform and to manage each patient's health and health expectations per how that plan is set up. So there's a lot of opinions out there about value-based care. Don't want to get into that today, but my overall advice is you're not going to have any choice in the future. You're likely going to be involved and have to negotiate yourself into those contracts in some cases. And that's where tracking everything you do through your EMR and that the logistics of how you run your practice is very, very important. And a lot of the practices we talk about, they say they get concerned about taking on, either acute or patients that are going to need lots of attention in the value-based model. And I think there needs to be a lot of discussion still there at national and state levels with payers on how that works, because we are just getting over a pandemic here where patients are now presenting with either some unusual or more acute problems than maybe that they've had in the past, either due to symptoms they experienced during the pandemic or otherwise. And so fee for service will always have some place, but there's no doubt value-based is the future and will continue to be. And so really, as a medical practice community, we have to work with providers at both the revenue side and the expense side on how to be the most successful in that space.
Any thoughts around what providers should be considering both in a fee-for-service model and a value-based care model for their contract?
Kind of back to the geography question. Where are you? Where are you located? What's around you? If you're in the southern areas of Florida and Arizona and Texas and popular retirement areas, then you're going to find yourselves in high utilization value-based care models. So again, it's going to be how you train your providers and how you work with them and explain, hey, in the past, we may be able to increase our revenue by seeing 3 or 4 extra patients a day, and under the value-based care or quality utilization model, that's obviously not the case. You can continue to do very well, seeing 13 or 14 or 15 patients a day in the primary care world or on the cardiology or GI or ortho side, managing the predisposed symptoms that a patient may have that will eventually lead to a procedure in the way the payer asks those to be managed. So again, I'd love to say we have a lot of choices, but when it comes to value-based care, at this point, it's learning how to, make sure the utilization in your practice is appropriate, but at the same time, value and revenue centric to ensure you're maximizing everything you possibly can for that patient on that plan. So again, a little bit more complex than I'm making it sound, but a discipline that many practices are having to polish these days.
Right. So I'm sure this is the question most folks are most interested in. What tips do you have around negotiating the best rates and making sure your contracts are at the highest reimbursement?
Yeah, a couple of things. I'd say work on expanding your services. I think the more you can show the payer how you're expanding your services, whether that's through joining a larger group, or whether that's expanding your own group, or whether that's taking on providers within your group that bring on new sets and new tiers of CPT codes and visit codes to ultimately ask for payment through the payer models that they're set up for. That's an opportunity when a negotiation comes up, right? You can sit with the payer rep for that particular plan and say, well, the last time we talked was whatever, date, and this is the type of practice we were, and this is what we're offering. Now we're offering X, Y, and Z. Well, that payer may know of a subset of patients that may have that chronic disease or that chronic illness. And now here as a practice, you're providing those services. It gives you an opportunity for a little bit of leverage. So again, expanding your scope of, your scope of services is important. Expanding your geography, kind of staying on the same theme. If we're an orthopedic practice and we have a couple of locations in one part of the state and we expand to another part of the state, or maybe out of state, and we're involved in some type of maybe management service model where we share overhead but have a larger patient base under a single tax ID, that's going to bring you leverage to potentially get a higher rate with a payer as you come back to the negotiating table.
When do you recommend, and we talked about this a little bit, but when do you recommend engaging a partner? When is it time to say, I need some help around contract?
I think there's a few ways to look at that, right? We've got nurse practitioners and PAs and doctors coming out of training as we speak, right? There's a new intelligent crop of providers coming out of the academic and preceptor and medical internship of their careers. And so, it's a little bit like getting your first credit card, right? You want to have a good credit score and have the ability to, to be able to practice and function. So when you're either opening that practice or, maybe, trying to partner up with somebody that's a middle careerist and a late careerist, it's important to understand, am I walking into a practice where, the work I'm going to do has a valuable commodity rate associated with it? And so, at that point, it's time to look for expertise. And so that, to me, that's the time, that you reach out, whether it's through consultancy, whether it's through a contract expert person, or whether it's through a revenue cycle management company, or even an attorney. In some cases, I think that's the time you do it. I think the other timing piece of all of that is, when do we bring a partner along? Oftentimes groups find themselves in consolidations, or they find themselves in expansions, and where they're not going to necessarily hold the reins anymore in a contracting perspective. So again, I think appropriate representation is important for either you as a provider or you as a group as you may be going forward. And again, looking out for, am I signing up for something that is better than what I have now? And if it's not, why not? And that's a good time to engage a contract expert that understands, kind of where we are in today's geography of medical reimbursement.
Right. I think there's also value in a contract specialist sees lots of different contracts, so they've got a lot more visibility than the provider group necessarily has, so they can help educate on trends, what they're seeing in terms of payer behavior versus kind of going in blind without any of that intelligence.
Agreed. I think the wider scope that you can affiliate with, the better, right? Again, the more scope of service you have, the larger geography you have, the more you're going to get the payer's attention. So, regardless if you're a large hospital system and you're negotiating your rates for associated clinics or physician enterprises that may be attached to your overall service methodology, it's not that much different than if you're a smaller group, right? You want to be able to show, hey, we've got scope of service, we've got geography, and we've got the size. So, focusing on those three is important.
Great. I want to give folks on the call a chance to ask some questions. So if you want to drop your questions in either the chat or the Q&A, we will start to answer those. All right. So first question, when is it time during the contract negotiation phase to say, this really isn't worth staying in network. I'm actually better off going out of network. And that might be a whole can of worms there, but
yeah, we get that question a lot.
yep.
Oftentimes I mention some of the smaller payers. And so oftentimes what we'll do is run a CPT code analysis for a particular group, and we'll show them, here's the potential out of network rates that you'll get from this payer. And at the end of the day, if those out of network rates, if you find those satisfactory and you feel like it'll, at least cover the overhead of your practice or maintain a patient population that you think is valuable to maintain, then I would say it's worth it. If you look at what you may get paid out of network and it truly ends up being kind of a self-pay effort, and the burden is ultimately on the patient, then, it may not be the best fit for your practice. But again, a true revenue analysis on what you may get paid out as an out-of-network provider, and walking through what that may look like on a monthly and annual basis is a great place to start to try and understand that equation.
Okay, great. We've got another question. Hi, I work for orthopedic surgeons in Nevada. Have you had any success in negotiating better fee schedules with Anthem, Blue Cross Blue Shield?
So, as a revenue cycle management company, we try and stay pretty neutral. But I do have friends in the industry that have done those things, and I've participated in those types of negotiations in former lives. Again, I would probably, stay along the same advice. When you're going to the table with very large payers like that, the concept is, again, to show, hey, I'm in an area where either, three things are going to change: scope of service, geography, or covered services, right? And so if this particular orthopedic practice is in Nevada, wherever it may be, Nevada is a fastly growing state. I think at one point Las Vegas was the fastest growing city. Then those are some of the pain points that you want to hit on with whatever large payer you may be negotiating with. That yes, right now we have X amount of patients or X amount of lives that we potentially pull from for orthopedic care, and 5 years from now we'll have this many. So again, the payer has to take some of that into consideration. Another thing to think about is, if there's another 500 orthopedic surgeons around you, well, then, that's also probably not the best for your negotiating tactic if they're all going to that plan at the same time. So again, carefully thinking through kind of some of these themes we've talked about are good tactics to either maintain the rate you have or explain why, you're the preferred provider, based on your quality and based on what your surgeons can do.
Mm-hmm. Yeah, you hit the nail on the head. They're in Vegas. So, yeah.
It's a good place to be if you're in healthcare. It's a good place to be.
Exactly. We have a comment. It seems that more and more payers are limiting out-of-network benefits like HMOs. Are you seeing that as well?
We have been seeing that, and unfortunately the patient loses in that one. I think that's something that needs to be discussed more in some of our lobbying circles, and whether that's AMA or American College of Physicians or whatever that looks like. We've got to kind of figure that out, especially again after the pandemic. We saw a lot of people leave their jobs, and we see a lot of people that don't have insurance that used to have insurance, and now they're signing up for more narrow network plans that aren't providing as much services. And so again, I would say at the end of the day, it's probably better to be in network than it is out of network, right? Because it'll at least coverage, it'll grow your patient population. And I would say to that, you can always exit a contract, right? There's no problem with exiting a contract. And oftentimes you can get 6 months into it and think you signed up for X and you're getting Y. Well, at that point, you can have that discussion and go out of network and, have that discussion with the payer rep. So, it's a little bit chicken and egg, but I still think it's an important opportunity. It's unfortunate that we're seeing out-of-network benefits narrowed, but again, that is the journey to value-based care, right? In the grand scheme of things, the 5 or 6 major payers want us to participate in health plans where we're also taking care of ourselves and taking healthy steps to ensure, our utilization is where it needs to be for our place in life.
Right. Another question here. What do you think the most important provision is in insurance contracts to try to negotiate or get removed?
The most important provision. For me, again, it is, scope of services. They're going to look at your evaluation and management codes. They're going to look at your procedural codes. And so, you can look at term, how long your contract is. You can look at what is in network, what's considered in network, and what's considered out of network. You can look at, as a new patient population arrives, will you have the opportunity within the contract that you're signing up for to provide those services, kind of back to scope. But again, at the end of the day, it's ultimately about, what you're going to get reimbursed of relative to the Medicare allowable for that tranche of CPT codes. However, the payer may be putting those together. So, for me, it becomes a financial analysis on each contract, and you want to make sure that is the, I don't know, what do we want to call it, lead dog of provision in the contract.
Great. I don't see any more questions, but as we get ready to wrap up today, what's your call to action for those that are on the call?
For whether it's administrators or finance folks or, other contract professionals, I would say it's education, right? I think a lot of us get so busy during the day, me included, and all of us, that there needs to be either somebody in the practice or somebody on your team. And again, whether that's the CPA or the medical group administrator, or whether it's your neighbor down the street who just happens to work in finance or something, but somebody that's paying attention to what's coming out, whether that's federal legislation, and we're talking about the highest level of CMS, and what's coming around the corner in the form of sequestration and physician service payment cuts. I think somebody needs, you need to be paying attention to that. And then the other big kind of piece in education is listen, the commercial payers, either now, months from now, weeks from now, years from now, they're going to fall in line eventually and follow the patterns of what CMS is pushing out for their governmental and Medicare Advantage plans. And so, eventually Blue Cross Blue Shield, Humana, Aetna, Cigna, United, they're going to line up. And so if the governmental plans are, big thing in cardiology right now, or a big thing in services is initial consults and follow-up consulting services are now not being reimbursed. So, there's going to be a trend of something like that going forward. And so I think education is very, very important. So, I know what we all have, whatever it is, another 50 or 100 or 1,000 emails to get through the day, but you need to put on your calendar 15 minutes or 20 minutes once a week or twice a week or something, and spend, that time educating yourself about what's going on and what's out there, and whether that's reading Becker's or reading HFMA or reading MGMA or, reading some of the lobbyist websites to really understand what's going on at the highest levels. And that's, again, you're not necessarily trying to be the smartest person in the room, but just be informed. So when you're representing your group or when you're sitting down with your physician partners, you guys can have an educated conversation about, hey, here's what we need to do. Here are the trends we're seeing. And if that's, again, reaching out to a medical, clinical utilization expert to have a look at, how the type of care you guys are providing and ultimately what that equals in reimbursement. And if you're able to step up that level of care and whatever that looks like to increase your reimbursement, then those are discussions you need to have. But education is no doubt the key.
All right. Well, thank you all so much for joining. Thank you, Bo. Lots of really, really, really good information as usual. We hope to see everybody back here next week.
Thanks, Ken.
Absolutely. Thank you. Bye-bye.